We talk about mutations. Remember, this is two viruses got in together. So the mutating positions that it has acquired, that how many times it can acquire, mutate is 39,000. Right now, my university is working on mutation. So we have described so far 129 mutations that we are encountering. But remember, long journey, 39,000 possibilities. This is the virus. I told you why it's called COVID-19. We already know this is the projecting pandemics, post-pandemic, how it is going to end. It's going to come endemic and then end. These are the multi-system disorders that I already discussed. This is what to show you in our patients when they really get ill is after 8 days, and after 2 weeks, they require ICU care. This is the cytokines you can see being generated through the macrophage white cells. This is host versus body reactions and things like that I discussed already. This is the purport cascade. You can see the airway virus, this over there, entering the lungs through ACE2 receptors, internalized and activating the white cells, what we call is macrophage, the polymorphs, and they become endocrine gland because they secrete so many things. Another thing they do is they activate these quiescent cells, dendron-like cells, we call it dendritic cells, and then they secrete inflammatory mediators like this, and you can see cytokines. Then the cytokines, there is a vicious cycle, they start damaging all the organs. Here you can see the virus entering the airway epithelium, charging the white cells, and you can see the tissue factor expression, activating the endothelial cells, covering the tile-like cells, covering our blood vessels, and then also procoagulant uh, factors come in, that the blood starts clotting within the blood vessel. You can see the microthrombi. Now they can go to the brain and cause stroke. They can go to the heart and cause heart attack and so much, what we call is embolization. Here again, you can see that once these the platelets which are there in our body, resting platelets are discoid shape, and once the platelets think that somebody has cut the endothelium, like if we cut with a knife, our hand, our bleeding stops because of these platelets. Now, this is endogenous damage. Nobody has cut our endothelium, but this virus has damaged the endothelium. So the platelet starts clotting altogether, and different receptors, A2 receptors, TMPRSS receptors, spike antibodies are being produced, which starts the clotting mechanism within the blood. Here, this is an electron microscopy picture, a beautiful picture that we tried to show that virus in the golden is directly attaching to our lung endothelium over there, internalizing it. This is the study we just concluded in the deceased people who died of COVID-19. A vast majorities, about 71% of these people, unfortunate people who died, had coagulopathy, clotting abnormality, thick blood, and clotting in different vascular bloods were there. While people who survived the disease, only 0.6%. So coagulopathy is very, very important phenomenon in anybody suffering from, and that is why we normally would ask for D-dimers and other factors to find out whether the clotting is there or not. This is the virus again attaching to the endothelium, blood vessel endothelium, you can see over there. This, by the way, is my University of Health Sciences. This is Pakistan Society of Internal Medicine. I happen to be president of that. That's why you see and both of these logos there. So endothelial damage, the inner blood vessel damage, then the microcirculation is damaged, then the liver is damaged, hepatic, cerebral, vascular, brain, heart, kidney, peripheral blood vessels, eyes, embolism can go anywhere. You can have Venous thromboembolism, deep vein thrombosis, like in pregnancy, sometimes can occur in this, and then small blood vessels keep on clotting. Usually we do for risk stratification in people who present to us, we do D-dimers to find out whether they have coagulopathy or not, or they are lucky enough that they do not get into thick blood problems. Lymphocyte count, I told you, tells us about the prognosis. So we do absolute lymphocyte count. Inflammation mediators are there, ferritin, CRP, ESR, we do, LDH. Fibrinogen level tells us again about the coagulopathy. Troponins, erythropoietin tells us about the hypoxia. This is an enzyme secreted by the kidney. Whenever there is hypoxia, this will be secreted, so it tells us. Cytokine estimation, we do interleukins and TNF-alpha assays to find out how much is the inflammation, and then we give cytokine blockers like Actimera or infliximab, and then we see the effect of blocking the cytokines, whether they come down or not. Procalcitonin is also very good hormone to monitor. We do ECG, we do echocardiography, which is the ultrasound of the heart. Usually we do high resolution CT scan of the lung to find out the extent of lung damage. This is, we usually, ground glass appearance we see on the lungs, and we categorize it, that ground glass appearance with less than 50% consolidation of the lung or more than 50%, which gives. This is the type of pictures that we see, that there is ground glass appearance on the back, and you can see the patches of pneumonias over there, usually on the periphery in the one or two lungs or both lungs. Here, the problem is the repair in this disease is through fibrosis. The elastic tissue of the lung is replaced by fibrous tissue very, very quickly, which obviously does not have that functional capacity of transferring the oxygen from air to blood. We manage fluid electrolyte, caloric intake, we do gastric protection. So if somebody vomits, doesn't take the vomiters to the lung. We do give heparin usually to prevent DVT. DVTs, we give oxygen, as we all know. We give broad spectrum antibiotics. We use non-invasive machines like BiPAP, CPAP. These are, we don't have to put in tube in the lungs. We just give it without putting in tube through high pressure, so that the lungs remain patent and they don't collapse. We in routine anticoagulate these patients who becomes moderately or severely ill, and this anticoagulation is continued for 3 months usually after. We use dexamethasone or steroids after the recovery trial. We were part of that recovery trial, and we thought people who get very ill or people who get very inflamed in the lungs benefit from giving steroids. Steroids are two-edged sword. Unfortunately, in Pakistan, they are being abused more than used. They are even being given in mild to moderate disease, which should not be the case. They should only be reserved for serious disease in hospitalized patients. Antivirals do have role initially. The virus is there only in the first few days. After that, the virus goes out, but the inflammation comes in. So at the inflammatory stage or post-viral stage, there is no problem. Usually the RT-PCR that we do is positive for first week, and then it is negative. Even if the PCR may be positive that we do in our university, we see that it can be positive for many weeks or months. That doesn't mean the patient is still harboring the virus. That this virus, because it's a large virus, once a reticuloendothelial system or spleen breaks it down or rejects this virus, it breaks it into small fragments, and those fragments are being picked by our test. That doesn't mean the active virus is present or people are infective. So there's no need to get your cell retested after the initial test. After 1 week, you can mix up with your family after wearing mask and taking the usual precautions, you don't need to be isolated because you are no more infective. Aspirin generally we give to everybody because it's a wonder drug. I happen to be president of Pakistan Aspirin Foundation also, and we promote aspirin use in people with or without COVID-19, especially if they are above 50 years, because this is a guardian drug from that point of view. Very inexpensive, but huge benefits, one of the wonder drugs of the last century. We can give plasma, but plasma has not shown a lot of promise. We did a study and we did not show any benefit. So we are using monoclonal antibodies in seriously ill patients. We use cytokine blockers. We are also using Spectra D2000 cartridge for dialysis machine. We pass the blood of the individual through the dialysis machine with this device, and this chelates or take out all the cytokine. We thin out the blood with antithrombolytics, like we give for heart attack. Sometimes we give in this. Colchicine is a drug that we were using for gout, but we have shown very good effect with this. Ivermectin is another drug which we are using as anti-inflammatory in arthritis, and this says Chemostat is a drug that we were using for myeloma, a cancer type of a disorder. And we have, me and my colleagues have shown that it's very effective in inhibiting dendritic cell activation. Rolan, similarly, we are doing many studies on Rolan as well as a neutralizing drug for this. Aspirin, I told you, it can inhibit virus binding, virus replication. Platelets, as I showed you, becomes active, change the form and shape and start clotting. It inhibits that. It improves your white cell function. It's an anti-inflammatory drug. Endothelial lining, the inner tile-like lining is protected. It can prevent micro and macrovascular injuries and also decrease lung injury. This is a study that we did, people who died of COVID-19. We compared them whether they were taking aspirin or no aspirin. Maybe they were taking aspirin because they had a heart bypass or they had a stent in their lung. So if they were taking aspirin, there was 27% less chance of them going into serious disease or to ventilators, and this study is about to be published. COVID treatment protocol, we divide people who are serious or not serious, mild, moderate, and serious. Serious disease should be treated in the hospital. We usually give antivirals in the beginning, like remdesivir, and then ivermectin and other drugs like dexamethasone, but used for hospital, not for home care. Unfortunately, in Pakistan, they are being abused right, left, and center, as is the practice, because you can buy anything off the counter. You don't need a prescription. We have done many studies. Remember COVID-19, once you are you're cured of it, it can always reoccur because the antibodies that you generate for yourself are mostly non-neutralizing antibodies, while with the vaccine, you develop mostly the neutralizing antibodies. So you do need vaccination even if you had COVID 1 or 2 times. PROTECT is a study that largest study, one of the largest in the world, 39,000 people in Pakistan. Pakistan randomized outcome treatment in coronavirus patients. So this is a multi-center study. I am the principal investigator, and we have shown that we have used 8 different agents in parallel design, and the 8th group got placebo, nothing. So we showed that antivirals can benefit initially, and also antiplatelet drugs. However, hydroxychloroquine showed minimal benefits in our study. And this is now available. This has been published in trials.com from USA. So you can look at it. Oral anticoagulation, yes, rivaroxaban, we have done this study. It's a drug which inhibits your coagulation. And usually once the people recover from seriously ill patient, in the initial we use heparin by injection, and then we follow it up with rivaroxaban or apixaban. These are the drugs which inhibit coagulation for about 3 to 6 months. Antiplatelet drugs like aspirin are given again to people who have COVID, or we recommend people who are above 40 years to take antiplatelet drug like low dose aspirin, 75 milligram daily. So God forbid, if they get COVID, their mortality will be reduced. Anti-cholesterol drugs like statins, atorvastatin, simvastatin, these are the drugs that we use to lower the cholesterol. They have anti-inflammatory effect. Anti-cytokine therapy we can use. Usually we are using anti-TNF drug and interleukin blockers. Oxygen can be given at home. There is no problem. Generally, people who recover, they may become respiratory cripple because of the permanent lung damage. And we are doing right now stem cell therapy in them. My university is very active in developing these stem cells and giving it to people who have recovered from this but has become respiratory cripples. Psychological support is important. Treating diabetes, hypertension, heart disease is important. Post exposure, if you do get like if one of the individuals in Pakistan or anywhere they get this COVID-19, what about the other family members? They may be exposed or think they may be exposed. We are doing a trial for this with the Rna, as I told you, and we are enrolling people. So we are giving people who have got exposure to post-exposure. And then we are also doing study of vaccines and coagulopathy. I'll discuss about it. Also vaccine-induced thrombosis. I'll talk about it because this is a little bit of concern. These are the studies that we get national and international approvals before we go into it. This is a study that recently released, being published in a very prestigious journal. We call it Victory Trial, Vitamin D, Corona Cytokine Storm Therapy. Very interesting vitamin D supplementation or optimum vitamin D level, because we call it a master vitamin. Immune system signaling inside the cells depend upon the adequate level of vitamin D. Vitamin D has many functions in the mother, child, in the womb or pregnancy, and beyond that, in preventing many, many diseases. We have done, more than 24 studies on vitamin D. We showed, me and my group, that 78% of Pakistanis, they are deficient of vitamin D. Out of them, 40% are severely deficient. The other are moderately deficient. That is why colds, flus, and repeated poor response to disease is there. We are the first group in the world to show that vitamin D supplementation of seriously ill patient in our ICU. We treated them with vitamin D and placebo. That means no vitamin D, but just drugs which were not containing vitamin D. Background therapy was the theme. And you can see the CRP, the inflammatory marker, and the coagulation markers were significantly decreased. So not only the biochemical improvement, but also the gene expression to the inflammation was also decreased once we supplemented with high dose vitamin D in our ICUs, giving soft gel capsules of 200,000 units every day. So vitamin D is important in COVID. Coming to the vaccines itself, the perceptions and misperceptions. My university has done so far 7 trials in from phase 1 to phase 3, and now phase 4 trials of different vaccines. And my university, alhamdulillah, has been one of the most active universities around the world. When the corona came in, as I said, we tried to convert this adversity into the advantage for our people, and we were successful. This is the topic by volume on Google or any search engine. The most talked about topic remains the vaccine. You can see the hits per day. And the most important questions asked were about COVID-19 vaccine. These are the vaccine map, as you can see. We so far have vaccinated about 3.5 billion people, at least the single dose, while the world inhabitates 6.5 billion people. Here you can see this is global dashboard. Pakistan, unfortunately, we are still struggling. This is the figure. You can see the countries who have vaccinated. Chile, the small countries. Israel has vaccinated about 80% of their population. Pakistan, unfortunately, is over there. We have vaccinated about 10%, 8 to 10%, and that also partly. So I'll talk about that in a minute. But good thing is over there, Pakistan, Alhamdulillah, especially University of Health Sciences is there on the efficacy trial map. The countries involved in the trials, we rate very, very high impact factor, as we call it, especially the University of Health Sciences. Vaccines, we have lost more than 65 million people in the last couple of years, since 2019. If you look at this dark tunnel, there is a dead body every meter. And unfortunately, yesterday we lost 88 human beings just in Pakistan in 24 hours, and these are the reported. Reported means the unreported you multiply by 4 or 5, because our reporting mechanism is not perfect. So this, at the end of this dark tunnel, a ray of hope is safe and effective vaccination program. So by that, we will not only save life, we can go back to the life which looks like a dream now for us, 2019 December, and before that we will live according to our wishes rather than this virus dictating us how to live. Vaccines, why we are so optimistic about vaccine. The reason is that our experience with vaccines is very, very good as human beings. Measles, the 99% eradication. If you look at polio, almost 100% eradication, you know, except for Pakistan and Afghanistan. Diphtheria, 99%. Smallpox has eradicated decades ago, and no smallpox case. Before that, there was a huge mortality from this. Whooping cough or pertussis, again effective. Mumps, 98% effectiveness. So we have very good vaccine success stories. We do usually phase 1 trials, which are small group trials, volunteers, 20 to 100 volunteers, and we did with Sinopharm phase 1 trials here in Pakistan. Phase 2 trial we have done with about 5 vaccines, and which consists of several hundred volunteers. And so far we have conducted trial of more than 200,000 volunteers at UHS. Phase 3 trials mainly. Vaccine is a protein that we take from this virus, some form of which is safe to be injected. Either we make the virus inactivated, or we make it dead by formalin, or we just take a unit of this vaccine. We don't we don't take the whole virus, and we inject it in your muscle, and it goes to your immune cells and produce an antibody response, mostly to the spikes. These spikes are injected, and you produce spike antibodies. And then when these are the B cells, the lazy cells which are lying in our immune system, which are governed by T cells, which are the circulating cells in the body. These are two types of immune cells. T cells are memory cells. They have long memories. They tell the B cells to produce antibodies because this is a foreign protein coming. So next time when the actual enemy comes into your body, you inhale that, you already have antibodies to neutralize that, and that then fails to cause disease. So that is the concept of vaccine. Immediately the B cells produce the, here you can see the antibody response, the cellular response after the infection. You can see the both B cell response, T cell response, and it lasts for a little while. Maybe T cell response lasts forever, like in case of polio, like in case of other measles, mumps, and rubella, it can last forever. We have different type of vaccine. I won't go in detail. We have vaccine where we use the virus which is inactivated or dead virus. Okay, we just use one fraction of a virus, and in this case we use spike proteins. We only inject spike proteins. We dissect the spike protein from the virus and inject that. So your system produce antibodies against spike protein. Or sometimes, like in CanSino or AstraZeneca vaccine, those of you who have injected, we take another virus which cannot produce disease in human beings, and we impart the genetic material onto that virus and inject it into your body. Now, we have injected a virus in your body which cannot produce disease in human beings. So no disease will be produced, but the message to your RNA system, to your immune system, will be communicated to produce antibody. Or the new technology that we used first time in the history of mankind is messenger RNA vaccine. This technology is not new. We were using this technology in developing anti-cancer and many other drugs, but in vaccines, this was used first time. Here, we are not injecting any virus or any portion of the virus. We are just injecting a genetic code, a message, and injecting that and telling your own immune cells to produce the antigen, to produce spike proteins, glycoprotein S, the spike protein. So your own system develops the antigen, and then the antibodies are developed, and this vaccine gets out of the system within 48 hours. So no, the potential is that this type of vaccines may not have any side effects because they do not stay in the body forever. They just get out of the system after giving that antigenic challenge. They are cleared by your system. This is just the example of viral vectors where we use another virus which is replicating, multiplying or non-multiplying vaccine, but they cannot produce disease in human being, but they are coded to act as an antigen. Here, viral subunits, the subunit like spike proteins are taken and amplified, and they are injected so that they give message to your B cells to produce antibodies through the helper T cell function. RNA vaccines, I already told you, these are just the coding material in a lipid and delivery system, nanoparticle. They are injected, and your immune system produce the glycoprotein S, and then the antibodies against them are produced. So they are considered more effective and good. The classical example is BioNTech by Pfizer and Moderna, and about 5 Chinese vaccines. China is producing 5 RNA vaccines. The problem is they do require a stringent cold chain. Most of the COVID-19 vaccines are designed for 2 doses, except for CanSino, the trial that we did, and also we know that Johnson & Johnson single-dose vaccine. These are the single dose. Otherwise, we think this is the study to show that what is the immunogenicity study, that how much immunogenicity or immune protection you get. You get maximum protection if the interval between the two doses is more. The less the interval between the two doses, the less the protection. So boost interval should be high. Generally, when we look at the vaccine development, you can see that we do lab studies, and then we do animal studies, and then we start phase 1 studies, preclinical, and phase 2. Depending upon the results, then we are authorized or allowed to go into next study. Normally, vaccine development will take in excess of 15 years. That is why it's very difficult process. But here, because people are dying every minute all over the world, so we were given emergency used approval, okay? And all the treatments that we are using so far are also experimental therapies. We do not have, to be honest, licensed therapy or evidence-based therapy for COVID-19 as yet. Similarly, the vaccines were given approval in parallel. Preclinical phase 1, 2, 3 trials were occurring. We were not waiting for one phase results and then starting the second. We were doing in parallel, and that is why we got so many vaccines. This is, remarkable. The mankind and all the scientists have done wonders. For the first time in the history of mankind, we have so many vaccines. And our weather friend contributed the most. You see, most of the vaccines came from China, and China was responsible for vaccinating most of the world. As you can see, followed by US. Unfortunately, Pakistan, because there is no biotechnology plant, we are unable to manufacture vaccine. Of course, we are repackaging a vaccine, CanSino, importing it from China and repackaging it here only. This is the example of messenger RNA vaccine, viral vector vaccines, where we used Sputnik, Johnson & Johnson, AstraZeneca, CanSino, the one we did the trials on, and Covishield, all these inactivated virus, where the virus Sinopharm, Sinovac, where the viruses have been inactivated or killed and then injected. Protein-based vaccine, we have used a platform, and then CHO and messenger RNA vaccine. Here, B cells, neutralizing and non-neutralizing antibodies, the T cells. The antibodies that you keep on checking, we don't recommend it, that you go and get anti-spike antibodies done. But people over here in Pakistan, they are going crazy. They are going to lab every day and seeing mari antibody बढ़ गई हैं, नहीं हुई. Absence of antibodies do not mean you are not protected, and high antibody titer do not mean, because that's you are testing is only B cell mediated immunity. While T cell mediated immunity, the long-term immunity, the memory cells, this immunity cannot be tested by blood test. So when you look at the protection, we have done many assays in many studies, the neutralizing assays. We take convalescent plasma. That means the people who are recovered from as a baseline, and then we compared antibodies to that. This is just research. We don't recommend it to be done in clinical settings. These things. If you have gotten yourself the vaccine, we think it's good enough. This is the estimating protection titer that we do. We think 20% of the convalescent titer with 95% confidence interval is an adequate titer, which tells you while with the infection, the protection is very little, while with the vaccine, you can see the normalized, the neutralizing ratio is very high. Unfortunately, the vaccines waning off effect is there with all vaccines, but less with messenger RNA vaccine, less with vector-based vaccine. You can see virus vector vaccines, but with some vaccines, there is a waning off effect. It does occur, but it does not mean that you are not protected. Messenger RNA vaccine you see right on the top over there. Variants of interest, VOI, and variants of concern. We are doing a lot of studies of vaccines with both of these variants, especially the Delta variant. You can see B117, the UK variant, the South African variant, and now the Peru variant, C37 variant. As I told you, this is a large virus, and with the mutating 39,000 mutating position. So only Almighty Allah can stop it mutating. It is going to mutate, and it will continue to mutate. And whenever it will mutate, it will become more in its infective potential, and its virulence or mortality will increase. So let's hope we can eradicate this virus with effective vaccination programs sooner than later. Otherwise, this may mutate to the extent that vaccine will become ineffective altogether. So what we have seen is that once you inhale this Delta variant virus, if you inhale one virion, one virus particle, it multiplies so rapidly into your body that to about 2 billion virions within 48 hours. So such rapid division of this multiplication, and that is why more chances of mutations and more chances of mortality and morbidity. Here you can see the efficacy of Pfizer and Moderna. Now, why we inject, why we get vaccinated is not because we want to protect any disease, so disease doesn't occur. No, the main reason we inject ourselves or our fellow human beings are to protect their life from severe disease. So we are looking at, as specialists in this field, on severe disease, that even if you get disease, you are not going to die, or you are not going to require the ventilator. So most of the vaccines, especially the CanSino that we tested, protected about 95% in Pakistan from severe disease. ZF 2001 is a triple dose vaccine. It's a novel vaccine. It's a cell-based vaccine, the first cell-based vaccine. I am the principal investigator for the global, for the whole world in this vaccine. And we are just concluding this trial now of around 30,000 volunteers. This is a triple dose, and this, the initially, I can tell you, it's effective, very safe, and it's effective against all variants. While the official results are still awaited, I'm giving you unofficial results. So the protection that you're looking from any disease is not that much, but protection from severe disease is the main outcome. This is the UK thing, that UK, you know, that the cases surged recently, you know, but the hospitalization was decreased. This is because they vaccinated most of the people. Now, UK vaccinated their adult, elderly people first, so you don't see the disease, serious disease in elderly. Now in UK, you see serious disease only in the young people, because they were not injected on time because of the priorities given. This is a study from my colleagues in Sri Lanka. Why I put it higher? Because most of people were injected Sinopharm in Pakistan. So it may encourage you that Sinopharm still is effective against the Delta variant, and that is what we have seen in Pakistan also. ZF 2001 against Delta variant, I told you, the one where I am principal investigator, it is effective, as good as against Delta variant as against Alpha, Lambda, or the wild type virus which came in from Wuhan in the first place. All vaccines are virus. So why the controversies? Here, you can see there are adverse events. There are adverse events of every drug that you take. If you take paracetamol, it can also harm you. You do not expect because these are foreign proteins, so they will have adverse effect. If you do not vaccinate people quickly or create herd immunity, there will be vaccine-associated enhanced disease. Because of the mutations and all these things, the vaccines the virus will become more virulent and will multiply more quickly. Multiple systems can be affected in children, myocarditis, heart inflammation, pericarditis, but 1 in 2 million people can occur, very little. Thrombotic thrombocytopenic thrombosis, that is the clotting problem with the AstraZeneca and also with Johnson & Johnson vaccines that were reported, the clotting, then the low platelets occurs 1 in million. So low platelets can occur. Acute disseminated brain disease can occur, encephalitis, myelitis, anaphylaxis, toxic shock syndrome, injection site cellulitis or pain at injection site occurs usually with Moderna, very notorious. Second dose of Moderna, not the first dose, but just some icing over there is fine. It takes care of it. Acute kidney injury, liver injury, very, very rare. All in all, I can tell you that the benefit far outweighs the harms. That is why the vaccine, you do not inject because you want to protect certain individual. You inject because you want to protect the whole mankind. If everybody is vaccinated, this disease can become history. And then we will be protecting people who are even not vaccinated. They're suffering from cancers or pregnant or very small children. They will be protected as well. New variants, of course, is of concern because, as I told you, the vaccines have lost their efficacy, especially Pfizer has lost the efficacy in Israeli study. But against any disease, not against serious disease. This is the Israeli study that Pfizer from 94% has come down to 64%, but only against any disease, not severe disease. So vaccines do not eradicate the pandemics. What eradicates is effective vaccination programs. So the economic impact could be, as you can see over there very clearly, 3.4 trillion a year. Unless we eradicate, we human beings are going to pay a heavy price for this disease. It will take at least 70 to 80% global population, which means more than 5 billion people to be vaccinated in short time. Otherwise, the virus will mutate so much, we'll lose this opportunity. So right now, till August this year, we have vaccinated only 11% of the population. So what will be the cost of health if we had no vaccine in the world? It will be $3.4 trillion. Vaccine only given to countries who produce vaccine, it will be $1.23 trillion. To all high income countries, rich countries, the cost will come down to 292 billion countries. If we give to high and low income countries, everybody gets vaccine, then the cost will come down drastically to $153 billion. So it's very cost effective. So the futures, we'll see, we are starting a trial of nasal vaccines in children. The CanSino has a nasal vaccine, transdermal vaccine, where needles can be avoided, and mechanism of, because this virus enters through nose, so it will be sensible to give a nasal vaccine, which will have a local effect also. We are looking at many newer vaccines, second generation and now the third generation vaccines, to overcome all these mutations and variations that are there in the virus. Immunogenicity trials, we are continuing to do, don't worry. Receptor binding domains, we are studying that how can we protect you by blocking your receptor binding domains here. Now, this is very interesting. This is our own work that we have done. We have done that when was influenza eradicated or partly eradicated or became endemic from a pandemic. At that time, they had to inject about 25% of population. Measles, herd immunity was created at 95% population was injected. Polio, you can see 89%. And looking at our ending the pandemic, looking at COVID-19, we think unless we inject at least 60 to 65% of the global population, it will not be eradicated. Now, as a doctor, I will not be nationalistic here. I'll look at things on the global level, because I know that unless I create global herd immunity, this disease is not going to go away. I tell you, in vaccine world, we always talk about nobody is safe unless everybody is safe. So we have to save everybody. We must be thinking on the global level and not on the nationalistic level. Because and that is why the COVAX was formed. COVAX was formed by rich countries for provision of vaccine to poor country. They were not doing any favor to us, because they realized that even if they create herd immunity, like in Israel it was created, and now Israel is struggling, unless they create herd immunity all over the world, nobody is going to be safe. So that is why they were subsidizing these vaccination programs. So key challenges now at the end remains variants and mutation, hesitancy, we know, and nationalism. We know there is a lot of still vaccine hesitancy, unfortunately, not evidence-based, not scientific-based. Aversion due to adverse events. I told you that we always look at harm versus benefit ratio, and in vaccines, it grossly sways in favor of benefits than harms. Discrepancy between supply and demand, especially in countries like Pakistan, which are low-income countries and not vaccine-producing countries. Regulatory standardization is not there because we are still giving emergency use approval. We do not have these vaccines registered as such because there was no time to get them registered. Absence of phase 4 or post-marketing trials are not there. So obviously the concern is that maybe in 10 years' time, these vaccines can be bringing in harm, but we are watching it, don't worry. And also, despite the vaccination, there could be breakthrough infections. This is UHS and Pakistan Society of Internal Medicine. Obviously, we are helping government to vaccinate at least 70 million people by end of 2021. UHS is possibly the only institution in public sector, because in public sector, we are the only institute which is working on vaccination and research in vaccination on many, many trials. We are engaged in community mobilization, like we are talking to very important group here for this reason, that we can play our role by talking to the parents, to students, to the teachers, and clear their misconception and perceptions. But unfortunately, as always, sometimes perceptions are stronger than reality. So we want to dispel them. We have done phase 1, 2, and 3, 4 trials by now. We have administered now more than 165,000 jabs in clinical trials. CanSino, we were the first ones to bring to Pakistan, and now that of 2001 and many other. UHS and myself is the principal investigator for a Chinese hamster-based, ovary-based vaccine on receptor binding damage, triple dose that of 2001 by An Hui, and we are also doing immunogenicity study. We are involved in many consortia all over the world. We have written 21 editorials and we have published more than 900 pages of literature so far on COVID-19 vaccines, and also many trials of COVID-19 itself. This is how our vaccination center looks like at UHS. We have many campuses, but we're doing this at our city campus, which is right opposite Punjab University. There are many organizations which are helping us with our trials, providing the volunteers. You can see we are very busy. We have more than 100 Chinese, 20 Europeans living with us right now because of this. This is a very interesting thing which will interest all of you, because many of you want to get Pfizer, Moderna, messenger RNA vaccine, despite they got Sinopharm or Sinovac or whatever. We and the WHO agrees to us that we do not know whether it will be safe to mix and match vaccines, because we do not have safety data. So what we have done, and here you can help us, and Madam Aisha, I will sending this link also, WhatsApp her. We want those people, we are hunting for those people all over the world to register themselves if they are involved in mix and match. If they have gotten more than one type of vaccine injected for whatever reason, travel reason, concern reason, whatever, or their uncle told or aunt told or doctor told. So if they have involved themselves, we'll follow them up for 3 years. We have got around 9,000 enrollments from US, UK, Europe, Pakistan. And coming week, we'll be sharing the interim results, but this will be results of only for last 6 weeks. We'll follow these individuals for 3.5 years to see if there are any adverse events if we mix and match. We'll be sharing these results. So my request is, those of you who can promote the enrollment, you will be doing a national and a human service by just opening this form of UHS. It's available on UHS website, and it takes 4 minutes only to fill this form, and we'll follow up from there onwards for any adverse events that occur. This is a survey that we did with IPOS on vaccine hesitancy in Pakistan, which was there in about 65% of individuals, unfortunately. So I'll conclude that COVID-19 is pandemic and likely to remain endemic for next 5 to 6 years. It's not going anywhere, so be prepared for online education or whatever we need to do. Local guidelines are very important, and we are developing that. UHS is constantly developing them. Critically ill patient be identified early in the disease, and we need to save their lives. We do not have evidence-based guidelines, as I said, and as yet, the management is only experimental therapies, and that needs to be done after obtaining informed consent from the patient or next of kin. Hypoxia, low oxygen level, and clotting remains the important modifiable risk factors that we treat. More evidence is desperately needed in the form of controlled clinical trials, which we are undertaking. Vitamin D supplementation, our own trial that I showed, decreases the COVID coagulopathy severity. The ray of hope at the end of this dark period remains in the form of safe and effective vaccination program. Unprecedented corporate social responsibility, because we provided masks, millions of people, we provided sanitizers, and we provided PPE to more than 300,000 doctors to protect themselves so they can treat patients in peace of mind. UHS converted this adversity into opportunity for itself and Pakistan with 39 clinical trials which are already been published on mutations, diagnostic, treatment, and vaccination. So in future, remember, if anything is likely to kill 10 million people in next few decades or in a year or so, believe me, it's going to be infectious virus, bacteria, germ, rather than missile. So why the leaders must revisit their priorities? Why invest on missiles and nuclear arsenal? Good leaders, good countries will, if they want to really protect their people, they must inject funds on health and health infrastructure and research. So, and that is where the misery can be alleviated, not by producing more bombs. Thank you, and Pakistan Zindabad.